the point is just knowing the approach to the diagnosis and understanding the different patterns. That's really all we want to know. Because if we, there's so many myopathic diseases as there are inherited metabolic diseases as there are inherited neurologic disease. So an entire textbook on myology would be about this thing. Okay? So, but bottom line is what we have always taught you from the very beginning is the prototype pattern is always proximal weakness. If it's proximal weakness, then it's myopathy. But again, our job today is just to introduce to you the different patterns of weakness. No? So, approach. So, somebody knocks in the pocket. No? So, position. So, to determine the correct side of the lesion, okay, and is it a lesion of the muscle channel, okay, or is it a disorder of the muscle structure, or is it a dysfunction of muscle metabolism? Okay. If it's an actual destruction of muscle, yung nahiwa, secondary to trauma, that's not our problem. Okay? So, but most other muscle diseases, whatever category they are, whatever the location, it's whether it is a metabolism, okay, the structure in the inside the cell, okay, or a structure in the cell membrane. So any of these can be a localization of muscle disease. Clear, no? So now we said levelize the lesion, no? But if you start talking about muscle disease, you can still localize the lesion further, aside from just saying it's a primary muscle disease. But there's no specific pattern that each of one will show unless you already have a working diagnosis. Okay? So, second part is what is the cause of the myopathy? Is it hereditary or is it an acquired myopathy? So, the third question is there a treatment? If there is a treatment, well and good. Like hypokalemic periodic paralysis or polymyositis, there is treatment. But for most of the other hereditary diseases, most of them have no treatment at all. Okay? So, 3 goals, 6 questions, 9 patterns of presentation. This was a lecture presented by Dr. Amato. Okay? Well, we attended this, I think, about 10 years ago in Boston. Okay? So, he is on Harvard, faculty, and is one of the authors of the Manual of Neurologic Therapeutics. Okay, the seminar we attended was Martin Samuels was the chairman of the seminar. So they gave the entire 2 days lecture on Manual of Neurologic Therapeutics, all Harvard professors. Okay, so sometimes you get free trips because you want to attend something special. Okay, and that's very, we were very privileged to have a special class from Harvard like that. Okay, so, you want, again, yun yung sinabi ko kanina. Okay, so, when a patient has weakness, okay, so primarily weakness is a manifestation. And when you have myopathy, it may be similar to a disease of neuromuscular dysfunction, weakness. It may be similar to Guillain-Barré syndrome, okay, because it is quadriparesis. Or it can be a motor neuron disease, okay? So you have to differentiate which is which. Okay, now, obviously, 1 and 2, when you do the deep tendon reflexes, they're hyperactive. Period. Okay? So, when you have a patient who complains with generalized weakness, but there are hyperactive reflexes, so you're only looking at 1 or 2. Huh? 3, 4, and 5, definitely hypoactive reflexes. Okay, at definitely neuropathy, 0 reflexes. As well as the plexus disorders. Neuromuscular, you already know, you look at the pattern. Okay, so just mentioned by Dr. Gab. And myopathy, you also look at the pattern of the weakness. Huh? So, obviously, you don't expect hyperactive reflexes in myopathy. In myopathy, you also look for sensory deficits. There are none. Huh? So, which here will also have no sensory deficit, neuronopathy and neuromuscular junction. If there is a spinal cord lesion, there is a sensory level. Clear? If it is peripheral neuropathy, it is what? Glavin stacking. If it is Guillain-Barré syndrome, the neuropathy is very, very big. Okay? Clear? So, this is how you localize where the lesion is. So, where is the lesion? Then you go further. It's already in the muscle. Is it in the muscle membrane? Okay? Is it the structure of the muscle membrane? Is it the channel? Is it the sarcomere? Is it the mitochondria? Is it an inherited metabolic disease? Is it a problem of the nucleus or of the supporting tissue? Supporting tissue, bakit muscle disease? Of course, when you have problem with the supporting tissue, when you have mostly inflammation of the supporting tissue, and that will also cause like myositis. Okay? Connective tissue disorders can manifest. And if the supporting tissue has a vascular problem, there is inflammatory lesions in the perivascular space, there is infarction of the muscles also. Clear? So, this is going further down the line, but usually the graduate neurologist should be able to determine which is the best bet, okay, among all these possible sites. Now, the neuromuscular specialist, okay, will probably be able to give you an accurate localization upon the first or second interview and initial workup. But the basic neurologist, graduate neurologist, will just tell you muscle disease. At we will only say it is a channelopathy based on our final working diagnosis. Clear? Okay. How do you confirm which of these are which? Nowadays, it's all, it used to be electron microscopy. It used to be a big thing. Okay? And secondly, ano tawag doon? Yeah, for most of these diseases, these non-metabolic diseases, for the structures, membrane, the channel, contractile apparatus, the sarcomere, the mitochondria, the nuclear, that is diagnosed mainly by electron microscopy. I don't know if still there's an electron microscope in the Philippines. I don't know. Okay, we all knew that we sent a specimen to Japan to determine for possible diagnosis by electron microscopy. Okay, but for those with disorders of metabolism, okay, and most of the other congenital myopathies, there are histochemical studies. Huh? Ah, so, sa ngayon, I think it's only Metropolitan Hospital who will be able to offer histochemical studies. No? So, during my residency, I spent 1 year developing the laboratory. Now, it's gone. Okay. So, when our teachers retired and the one who initiated the laboratory passed away, the subsequent department heads did not focus on histochemical staining of muscle disease. Okay, so there's more money on stroke research than money on neuromuscular disease. So now I think my friend says only in Metropolitan they can still do the histochemical studies. Okay. So, because they have a complete set of technicians. So, determine the cause. The next question. What is the cause? Is it hereditary or is it acquired? So, among all these things, you have the muscular dystrophies, the congenital myopathies, the myotonias, the metabolic myopathies, mitochondrial, okay, and congenital myasthenia. Myasthenia technically is not a myopathy. Clear? Okay. So acquired inflammatory polymyositis, polymyositis, dermatomyositis syndrome, thyroid myopathy, okay, steroid-related myopathies, systemic illness myopathies, drug-induced and toxic myopathies, and neuromuscular, well, again, nilalagay lang yan for differential diagnosis. Okay? So, does the patient have negative or positive symptoms and signs? What are the negative symptoms related to myopathy? Loss of function, particularly weakness or fatigue. Atrophy of the muscles or scapular winging. Okay? Positive symptoms, myalgia, rippling muscles, myoclonic jerks, muscle hypertrophy, contractures, and stiffness and inability to relax. Okay? Those are positive symptoms. These are more disturbing because they produce disturbing manifestations. And the negative symptoms, you don't notice them. Clear? The sarcopenia of the elderly, is it a muscle disease? No? Muscle wasting because they're not doing anything and we're getting old. Okay, so I think I'm developing sarcopenia. Muscles are degenerating. We start having difficulty walking as fast as we used to do. Okay? So, we deny that. We try to deny the reality by walking up the AUF Medical Center from 2nd to 10th floor without taking the elevator, and still you get up faster than those who waited for the elevator. Tama? Okay. Also here, I see a lot of students waiting in line for the elevator. It takes almost 4 minutes from 4th floor to go to 1st floor. Okay, so it takes 1 minute for me to go to the 4th floor. Hinihingal na lang ako, pero at least it's faster. Okay, and you also avoid being contaminated with infectious disease. Okay. And hearing a lot of marites in the elevator. Okay. So, you ask about positive symptoms or negative symptoms. Next is onset, temporal profile. Okay? When did it start? How did it start? Okay? Is it continuous or is it progressive? Or is it episodic? Okay? So, you ask those questions about the course of the illness. So, next you look at the distribution of the weakness. Is it proximal, distal, both proximal and distal, or is it only axial? So, those are the main questions that you ask. So, And do you have scapular winging? Okay? Or is there a prominence of bulbar manifestations? Weakness of the facial muscles or cranial nerve muscles. Okay? So, and are there things that trigger the illness? Exercise, okay? Immediately or after a prolonged exercise. Okay? Or after exercise followed by rest, after a carbohydrate meal. After a carbohydrate meal, hypokalemic periodic paralysis. Bakit? You eat a lot of cake. You eat a lot of cake and ice cream. Insulin goes up. Insulin goes up to reduce the blood sugar. When blood sugar is brought intracellularly, it brings with it potassium. And potassium goes down. So it produces hypokalemic periodic paralysis. Clear? Okay? So, can it be aggravated by cold, or are there any associated intake of drugs or toxins? So, is there a family history? Okay. So, X-linked. X-linked means there's only the one with the, X-linked are mostly recessive. Okay. So, if it is X-linked, females have 2X. So, females may carry the gene, but since it is recessive, it will not manifest. Okay. The male will have an X and a Y. So, if the male has the gene, it will manifest. That is the most common presentation of X-linked dystonia Parkinson XDP. X-linked dystonia Parkinsonism syndrome, or Lubag. Or when we were younger, the term was torsion dystonia of Panay Island. Okay, Panay. Where is Panay? Iloilo, Bacolod. Okay, kasama ba yung Negros? Anyway, Panay. So when we have a patient with progressive myopathy and there is a family history and probably it is X-linked, okay, we ask them, where are the roots of your family? Are there members of your family coming from these particular islands? Why there? We don't know. But at least, it made somebody famous in the Philippines. Her name is Dr. Lillian Lee. So, she's the oldest, the mother of all child pediatric neurologists in the Philippines, who is not a pediatric neurologist. Okay, she was because she went to Panay to gather data on all of this and presented it to the world. Okay, so now in the books, her name is attached to this X-linked dystonia Parkinsonism. Okay, and up to this day, you cannot do research on this without including her name. You will be scolded. Okay, no? The latest research on this was doing, ano mo yun, yung deep brain stimulation for treatment of patients with X-linked dystonia Parkinsonism. So they were able to receive a grant for, I think, 5 patients. So, back na. So, what are the associated signs or symptoms? Rash, fever, all these signs and symptoms will more or less give you an idea. First, most of these signs and symptoms, like dark urine, okay, demonstrate myoglobinuria. What does it mean? There is an active deterioration of muscle. Okay? Fever means inflammation. Common in polymyositis, dermatomyositis, or rashes, contractures as a result of atrophy of tissues. The muscles actually become, but the extremities become stiff and contracted. Okay, this morphic feature basically because of the weakness and lack and the and atrophy of the muscles. Well, I don't know about GI, but cardiomyopathy is muscle disease also. Okay, so the the end of life of this particular patient is respiratory paralysis. Okay, when they cannot breathe anymore, they die, and that will take a long time. And but if the family can afford, uh, the family can afford to keep the patient on endotracheal respiratory support, then the life of the patient may become longer. Okay. So probably if your mind is still very productive, you can write books, create theories, give lectures like Stephen Hawking. It's worthwhile keeping you alive for 20 years on respirator because your intellectual production, okay, is productive and funds your family and funds your life support. Okay, but if you're nothing, okay, if you're nothing, you have no skill, there is nothing you can add, contribute to the world, to the family, nobody will spend for you. Your own family might even measuring. Okay, what's the reality? Diba? Measuring. So if we keep you alive, okay, how many family members will work? Okay, what's the average salary for anong tawag doon? Call center agents? Something between 40 to 60,000. What's the nurse's salary? 30,000. Okay. No? So how much will you spend here for a patient who will be on respirator? Maybe 10,000 a day. Okay, so what will keep the family alive? So then we go into asking Dr. Sanchez, what are we going to do? Okay. Huh? What are we going to do? So just the basic principles. Does Father Marvin still give you class? No? Okay. So there's such a thing called extraordinary measures. Okay? Huh? Then there's the other thing called principles of double effect. So those are the bioethical issues that you have to deal with. So other signs and symptoms are usually associated with inherited metabolic diseases. Clear? So, as you ask those questions, you are already trying to localize the lesion and you are trying to narrow down the category of the disease. Okay, which is actually the proper neurologic approach to diagnosis. Clear? Okay, clear. So, according to Dr. Anthony Amato of Harvard Medical School, for general neurologists, it's better just to have in mind 10 particular patterns so that it's easier for you to make a diagnosis. Because you don't know what questions you're asking. Okay? When you're doing the interview, there's so many myopathies. All we know was what was taught to us, hypokalemic periodic paralysis, ano pa, inflammatory myopathies, at saka metabolic myopathies. Yun lang alam namin. Okay. Saka pala yung the prototype which is muscle dystrophy. Apat lang. But there are different patterns. Okay. So, when the pattern does not follow what I know already, I start preparing elsewhere. Okay. Clear? Oh, by the way, ancillary procedures before we do with the patterns. EMG and CB. EMG and CB. Usually, the nerve conduction velocities will be normal. Simple lang. Normal. Nerve conduction velocities are normal. Okay? So, the problem is the muscle. So, what's the problem with the muscle when you do electromyography? Okay. So, since it's a general, it's like comparing Filipinos, you know, yun, ano pangalan nung Physical Asia. Okay. So, you compare Filipinos, okay, no? Yan, against the Australians. Okay, at saka yung mga Turkish. Ayan, di ba? Ha? So, disregarded na yung Pilipino, talagang matatalo na. Okay? Because generally, they're weak. So, in myopathy, the muscles are all weak. Okay? And atrophied. So, when you ask the patient to contract, the electrical activity is small. Clear? Okay? But they're all together. They're all together. When you ask everybody, let's move, they all move. Kasi, there is no problem with the nerves. So everybody moves. They're all small, but they're all weak. Okay? Just like what is happening nowadays in tennis. Okay? No? They didn't realize that the best market for tennis is a Filipino crowd. Okay? No? Alex Ayala lost last night. But they never saw full packed crowds. Okay? From round 1, okay, kahit na qualifying rounds pa lang puno na kaagad kasi puno ang cheering squad. Okay. So, I'm trying to compare that with what they call recruitment pattern. You ask the patient to contract, mahina nga. But when you look at the EMG, all muscles are actually contracting. Compared to neuronopathy, ALS, only the few muscles are contracting. Clear? Kaya poor ang recruitment pattern. Then the other EMG finding is, there are no spontaneous muscle contractions, no fasciculations, no fibrillations. Clear? Okay? Ano pa? One of the first laboratory tests that I request for a patient with suspected muscle disease is a total creatine kinase, CPK total. I have to put total because there is CKMP, no? Okay? Tama? For the heart. Okay? So, total CPK. What does total CPK mean? If it's elevated, it means that there is active destruction of muscles. Clear? Okay. For inflammatory conditions, you add in ESR or C-reactive proteins. If they're elevated, then there is an inflammatory response. Clear? Okay. Then of course the metabolic things you rule out. But most of the time, the total CPK is elevated only when there is active destruction. They bring you already almost dying patient with muscle dystrophy. You do the CPK, it's normal. It means that there is no active destruction. All the muscles have already been destroyed. Clear? It does not rule out. So, proximal limb girdle weakness, which can be acute, subacute, and acquired. So, among the more common one would be the inflammatory polymyositis, dermatomyositis. Okay? So, the proximal muscle weakness, proximal. Clear? toxic drugs, endocrine, thyroid myopathy, and even the steroid-related myopathies. Okay. Huwag mo nang isama yan. Okay. Chronic congenital most dystrophies. Okay. Limb-girdle muscle dystrophy, Duchenne muscular dystrophy. Okay. Mitochondrial myopathies, amyloid, okay, including inflammatory myopathies. So, manifestation. The earliest manifestation of proximal muscle weakness is inability to raise the hands. Okay, over your head. But they can do the buttoning and unbuttoning of the muscle, what do you call this? Of your muscles. Okay, clear. They can do that. That means the distal are strong, but the proximal are weak. No? So, going up the stairs is difficult because the proximal muscles are weak. And for that same reason, in children, they have to do what they call the tripod sign to be able to get up. So, that's the typical proximal muscle weakness. Okay? And when you say limb girdle, okay, so that's the girdle. Huh? So, ayan. Yun yung proximal muscle weakness. Clear? And these are the different conditions that causes the proximal muscle weakness. Distal muscular dystrophies or myofibrillar myopathy. If I see patients with like this, my first consideration will be ALS. Kasi distal, right? The manifestations, inability to have even a grip or proximal atrophy of the muscles and all those things. Clear? Not unable to do fine things with your hands because of the muscles, distal muscles, and maybe this can result in bilateral foot drop. Clear? Okay? So, it looks just from the name, they're already rare. Okay? They're already rare. How do you differentiate them from? Ano yung first differential diagnosis dito? ALS. Okay? ALS, distal muscle weakness, no sensory deficit. Clear? Okay? But then, you do the deep tendon reflexes, ALS, they're hyperactive. Then you look at the muscles, there are spontaneous movements, fasciculations. Clear? So you know that it is not ALS. Oh, clear? Another issue would be Globen-Stocking sensory motor neuropathy. The difference between this and distal sensory motor neuropathy, Globen-Stocking, is that in distal sensory motor neuropathy, there is numbness of the hands and feet. Clear? Oh, na-differentiate mo na kaagad. Right? Right. Okay. So, myotonic dystrophy type 1. Myotonia. Okay. Yan ba yung papay? Okay, myotonic dystrophy. Myotonia means the muscle is hyperactive by itself, and a little stimulation can cause it to contract. Okay. It may produce weakness, okay, but not necessarily the weakness that we see in the other things. Okay. There is weakness, but they cannot contract. But actually, they have a hypertrophy of the forearm muscles. Okay. Which you need when you're doing, ano yung tawag ng uso ngayon? Bouldering. There's this bouldering place in friendship. When you're bouldering, you're supposed to develop your grip strength, and you will see the grip strength by having the muscles similar to my favorite cartoon character, Popeye. Okay, Popeye the Sailor Man. Okay, why does the sailor have big proximal muscles? Because they can go up the rope all the way up to the height to the sail. Okay, so that's why they have. Okay, so central myopathies, these ones will have atrophy. Okay, so distal weakness is not all peripheral neuropathy. It's not all ALS. It's possible for myopathy also. Clear? But we were able to differentiate one from the other. Okay. So you have scapuloperoneal. So proximal arm and distal. Okay. So the name facioscapulohumeral. So just looking at the name, scapuloperoneal, it follows that particular pattern. Okay. What would be interesting probably in the exam would be using the word Emery-Dreyfus. But if you use the humeroperoneal, you already know the answer. So the question here is, if a patient is diagnosed with Emery-Dreyfus myopathy dystrophy, what is the pattern? 1, 2, 3. Patay. Okay, no? Bahala na kayo. That is a remembered question. Clear? Clear? Or vice versa. A patient has proximal arm, distal leg weakness. Okay, which of the following is consistent with this? Clear? Yes? Okay. Distal arm, baliktad naman, and proximal nerve weakness. Okay. Inclusion body myositis. Okay. Myositis. So, ano yung pinakamalapit kay myositis? Polymyositis, dermatomyositis. So, because it is an inflammatory lesion. Okay. But what makes it different from polymyositis, dermatomyositis is the distribution of weakness. Lower extremity and distal upper extremity. Clear? Okay. Remember question. Inclusion body myositis. What is the pattern? Clear? Myotonic dystrophy. Uncommon presentation. Bayaan nyo na yun. Okay. So, ptosis without ophthalmoparesis. Okay, pattern 5. Ptosis is the manifestation. Okay? So, myotonic dystrophy, congenital myopathies. Okay. Obviously, differential diagnosis is neuromuscular junction whenever you have ptosis. But again, if it is a myopathy, the ptosis will be always there. Clear? Whereas in neuromuscular junction, it comes and goes. It is relieved in the morning. That's why you have to ask the history. Ptosis with ophthalmoparesis, kasama pa rin si neuromuscular. But the thing is, in neuromuscular, there may be ptosis here. The diplopia can be anywhere. Okay? It's the individual muscles that are affected. Clear? Okay. Of course, you have oculopharyngeal dystrophy, mitochondrial myopathy. Okay. Prominent neck extensor muscles. Isolated neck extensor myopathy. Obvious siguro yun sa remember question, no? Okay. So, inflammatory cervicobrachial myositis. Okay. So, bayaan mo na yan. Okay. Pattern 7. Episodic pain, weakness, myoglobinuria with trigger. It's common to most metabolic myopathies. glycogenosis, and lipid disorders. Clear? So, episodic pain, weakness, and myoglobinuria associated with exercise are usually due to inherited metabolic diseases. Clear? Okay? Episodic pain, weakness, myoglobinuria, not related to exercise. Malignant hyperthermia, drug-related, prolonged intensive exercise. Okay, so one patient like this overexerted himself, got hospitalized into ICU. Okay, trauma, polymyositis, dermatomyositis, viral or bacterial infection, or neuroleptic malignant syndrome. Ito na kaya. Malignant hyperthermia or neuroleptic malignant syndrome is common sa inhalation anesthesia. Okay? Halothane. Okay? But also common among the first generation antipsychotics. Okay. Well, I had a death on malignant hyperthermia because of the first generation antipsychotics. And that bothered me a lot. Okay. Episodic weakness delayed, okay, or unrelated to exercise. Pattern number 8. Periodic paralysis. So, sodium channelopathies, calcium channelopathies, okay. Secondary periodic paralysis, thyrotoxicosis. Okay. Whatever that is. Andersen-Tawil syndrome. What is that? Okay. Number 9. Stiffness and decreased ability to relax. Okay. So, which improves with exercise, myotonia congenita, which is a sodium or chloride channelopathy. Okay. Or something that worsens with exercise, paramyotonia congenita. Okay. So, stiffness, decreased ability to relax. Okay. Fixed weakness, myotonic dystrophy, myotonia. Myotonia lahat yan. Okay, kasi decreased ability to relax. Clear? So, if all the other muscles are involved, then one of my first patients in 1989 was a 3-year-old, this big. Okay, they just bring him to the clinic, this big. He can eat, okay, he's awake, he cannot talk, mentally retarded. He's always having the myotonic contractions all over. So, you look at his muscles, his body, he looks like a bodybuilder. Okay? So, yeah. During my first few months in practice, I had this particular patient. So, we already know this, which are the acquired and which are the hereditary. Classification. What are the channelopathies? Okay. So, myotonic dystrophies, which are the chloride channel myotonias. Okay, these are these ones. Okay. Sodium channel myopathies. Okay, and you have dyskalemic episodic paralysis, hyperkalemic periodic paralysis. So these are the channelopathies. Okay? Tapos na tayo dyan. Positive and negative symptoms, exercise tolerance, fatigue, positive symptoms, we mentioned that. Myalgias, these are the different conditions which could produce myalgia. Myalgia will usually be associated with an acute injury to the muscle, whether it be metabolic or whether it be inflammatory. Okay? You would rarely see myalgias in the chronic dystrophies unless the degeneration is actively going on. Okay? But since the dystrophies are chronic diseases, they're not likely to produce myalgias. They will only produce myalgia during acute exacerbations. Clear? Okay. Contractures. Okay. So, as a result of prolonged, most of them anyway will cause contractures. As a result of prolonged atrophy, hindi ko na edit. Okay. So, stiffness. Mostly the myotonias produce stiffness. Okay? Which produce rhabdomyolysis, toxicity. No? Okay? In medical school, in the past 40 years, the most common cause of rhabdomyolysis and myoglobinuria among medical students is
Caffeine.
is
Caffeine.
trauma. Okay. Fraternity initiation. Okay? Okay, as a result of myoglobinuria, it can cause chronic renal, acute renal failure. So, there's quite a number of, anong tawag doon? Initiates who have died from chronic renal failure. Okay? One of our classmates was, two of our classmates were hospitalized in the ICU. Okay? For a long time. And then another classmate was also hospitalized because they put hot iron on his back. Okay. It's not supposed to be placed on the back. Okay, only to psychologize. But I guess he moved. Okay, or somebody else put. Okay, so that's why it caused a mark. So, first year medical school, USD was always on the front page. Okay. Okay. So, myoglobinuria. Well, yeah, as I mentioned, all those other things. Another classification, which are the myopathies at birth. Okay? Remember, just know, no? You just need to map out that these are the different myopathies at birth. It becomes difficult. Myopathies of childhood. Mostly, those at birth are the myopathies that are associated with metabolic disorders. Okay? No? And the dystrophies. Myopathies of childhood, among them are the muscular dystrophies. Okay? Prominent one. Myopathies of adulthood. I would not know anymore. Basta alam ko lang myopathy, period. Okay? So, this one, endocrine and inflammatory myopathies and metabolic myopathies, probably we can clinically diagnose. And maybe when I see a patient with limb-girdle, scapulohumeral, Becker, Emery-Dreyfus, Kennedy, and all those things, the final diagnosis actually comes from my friend from Metropolitan Hospital. Again, the name is Dr. Raymond Rosales. Okay? Huh? So, and he will just tell me this is what you do. This is the final diagnosis period. Okay? So, patterns of inheritance, this one is important. So, you have to have an image of this in your brain because we can get a lot of questions from this. Clear? Okay? So, Duchenne muscular dystrophy, Emery-Dreyfus, Becker's muscular dystrophy. Autosomal dominant, okay, these are the ones. The myotonics dystrophy, periodic paralysis, Thompson's disease. Limb-girdle muscle dystrophy type 1. Autosomal recessive, ayan, Becker's, okay? Maternal transmission, mitochondrial myopathies. So, inflammatory, no, these are toxic neuropathies, no? Okay, mali yan. So, these are, again, yung toxic myopathies. Myopathies may be associated with cardiac disease, ayan, okay? And those with congestive heart failure. Inherited, this is the ICD classification of the different myopathies. These are the different muscle dystrophies, as we have mentioned a while ago. So, Duchenne, limb, girdle, okay? Emery-Dreyfus, proximal, upper, and distal, okay? Limb girdle, type, ano?
Core.
Type 1? Type, ano yun? Wala, basta. Facioscapulohumeral, okay? And this one is oculopharyngeal because it involves face, no? So, there. Types of muscle dystrophy, these are the pictures from Netter. This is the Gower sign. Duchenne muscle dystrophy, biopsy, most of the muscles that you get are all small. Clear? And the point is on H&E staining, you won't be able to find inflammatory response. If there is inflammatory response, then it is polymyositis. You see WBC mononuclears all around. Okay? All around the muscle fibers. Okay. This one, H&E staining is easy to do. You call a surgeon, remove a muscle from the cup, okay, and send it to the lab. Okay. However, if you want the pathologist to have a better anatomy, by the time the specimen goes into the formalin, the muscle would have contracted. Okay, the muscle would have contracted. So, when they do the specimen, when they do the paraffin, yung processing, dehydration and paraffin and whatever, blocking, and by the time they look at it on the specimen, all the muscle fibers are already messed up. Besides, you have to slice actually. Okay, you don't slice on the longitudinal direction. So, it takes a lot of skill to do this. You don't do formalin staining, because you won't be able to demonstrate the exact anatomy. Clear? So what do you do? How can you make sure that the anatomy is perfect? Okay? After removing the specimen, dip it in liquid nitrogen. Okay? So you buy liquid nitrogen. You bring a thermos, go to the supplier, they put liquid nitrogen, then that's what you do. Okay? Parang thermos na malaki. So, the same thing that now the chefs use liquid nitrogen. Okay, but we used to have a supplier for liquid nitrogen. So, we developed a procedure. It took us a lot of muscles to make sure that the anatomy would remain intact with liquid nitrogen. Then, if it's with liquid nitrogen, you cannot do paraffin staining, paraffin processing. Okay, you have to do a frozen section. So, diretso dapat siya sa frozen microtome. Okay? So, then, when your technique is wrong in dipping it into the
Liquid nitrogen.
liquid nitrogen, what will come out will be bubbles all over. Okay, so that's how I wasted my entire second year of residency. Okay, but we were able to perfect it and were able to do different histochemical stainings by the time I graduated. Okay. Uh, with no additional skills to use in clinical practice. Di ba? Okay. So, so 2 weeks ago, we were in Sapporo. So now I realize I did not make a mistake of not going there to train for my fellowship. Because my professor said, you go there, Sapporo, give Niigata in Hokkaido to study pathology. If I'm going to the province, ang ire-repair na lang nila sa akin yung dead. Okay, so it's not going to. Nobody does autopsy anymore. So I think I made the right decision at going for residency. Hokkaido is very cold. Okay. And very lonely. Myotonic dystrophy, these are examples coming from may nakasulat ba dyan? Dive bomber? Wala. And somebody search YouTube dive bomber sound on EMG. Dive bomber. It's like the Tora Tora airplane diving into okay, so but you're hearing the engine of the airplane diving okay, no, to hit a target. Okay, walang nakuhang sound. Parang tricycle na dumaan sa kapitbahay, gano'n. O, ngayon. So, basically, that's it. That's the same sound that the Tora Tora airplane makes when you hear them going for a dive and trying to hit a target. Okay? Clear? So, in simple terms, tricycle sound. Okay. No? Especially if your house is just right next to the road, the highway. So, congenital myopathy. Anong ibig sabihin ng Nemalin? Latin term for Nemalin. Parang tiger. It has something to do with the tiger because the patterns are like stripes. Okay, no? So core, you see something in the core of the cell. Okay, these are diagnoses by electron microscopy. Okay, centronuclear myopathy, congenital myopathies. Okay, the flappy infant. Okay, where else did you hear the flappy infant? Motor neuron disease, Wernicke-Hoffmann disease. Okay? So, mitochondrial myopathy. So, in my 40 years in neurology, I found I had one patient with MELAS. Okay, the diagnosis was confirmed by one of the prominent child neurologists in Manila, si Dr. Gan. Benny. Dr. Gan. Okay, she's now I think the chairman of the Child Neurology Society of the Philippines. Okay, my patient manifested with seizure disorder. Okay, but she was able to. She told me, Doc, I'm sorry to inform you that your patient looks like she has MELAS. We sent specimen for genetic studies, okay? And she's going to die. So she passed away already within, I think, about 4 years after she was diagnosed. Okay? So, MERF, myoclonic epilepsy with rugged red fibers, because they see rugged red fibers on the in the specimen. Okay? So, and it's basically the disease mitochondria, which appear as rugged red fibers. Okay? Huh? So, experience, iron, ano na yan? Okay, inflammatory, as we mentioned, inclusion body myositis, similar presentation to polymyositis. And it does not respond to the drugs that effectively treat polymyositis. What do you do for polymyositis? Mostly steroids. And but polymyositis, you look for the underlying cause. Polymyositis, dermatomyositis, though they respond to steroids, the underlying cause is usually neoplasm, an occult neoplasm. Therefore, mostly, polymyositis, dermatomyositis are labeled as paraneoplastic syndromes. Okay? So, clear? So, it's usually among the elderly, pain, myalgias, and proximal muscle weakness. They cannot get up the bus. Okay? So polymyositis, you can see that there are mononuclear infiltrates in the interstitial tissue. Okay? Inclusion body, there are inclusion body inside the cells. Okay? Dermatomyositis, they have also the same in the skin. Okay? Hypokalemic periodic paralysis. Diagnosis, serum potassium. More often than not, the serum potassium is normal, okay, or a little normal. But you start worrying when the serum potassium is below 2. Okay. Actually, 2. 2 plus or minus 3 points. Okay. Why? Because it can cause cardiac arrhythmias and the patient can die. Okay? Second, you treat this, it's treatable. You give potassium. Okay? You give 40 milliequivalents potassium. If you inject the potassium directly, what happens? Huh? What? Tataas yung potassium niya. Very good. Ha? Tama? Tataas yung potassium niya. Hello? How do you administer potassium? Slowly. So you will usually incorporate it only in the IV fluids. Because if you inject it directly, you kill the patient. The patient will die of cardiac arrest. Okay. In fact, KCL is included in the cocktail for lethal injection. Clear? Okay? Endocrine myopathy. Okay. So, I think this is Cushing syndrome. This one probably since she's payat na payat. Addison's. Okay? That's it. Any question? Any questions?